All right, so good afternoon, everyone, and thank you for joining us. My name is Eliana Landa, and I'm the Physician Relations Specialist here at Rothman. Today's webinar is with Dr. Moncman, orthopedic foot and ankle surgeon. Dr. Moncman's office locations are in the Training Center, Innovation Tower, and Winter Garden. The topic that she'll be covering this afternoon is minimally invasive bunion correction. So just a quick few notes. At the bottom of your screen, you will see a Q&A icon where you can enter any questions you may have throughout the presentation, and Dr. Moncman will have time at the end to answer as many questions as she can. Also in the chat box, I'll share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance that you may need. This webinar is being recorded and you will all be emailed a recording within a few days. So without further delay, I will pass this off to Dr. Moncman. Welcome, Dr. Moncman, and thank you for your time.
Hello, everybody. Thank you so much for having me. I'm excited to talk about one of my favorite topics and procedures, which is the minimally invasive bunion correction. So let me just pull up my PowerPoint here. All right. Can everyone see that? Or Eliana, I guess you can see that?
Yes.
Awesome. All right, so we're going to be talking about minimally invasive bunion corrections. Right. So just to talk about what we're going to go over, I'll give you a little history about our traditional open approaches. We'll talk about the MIS technique itself, MIS being minimally invasive surgery. So we just kind of abbreviate it as a MIS bunion. We'll talk about the pros and cons, both for myself and for the patient. I'll talk about my experience with this procedure, and then a little bit about what the literature says. All right. So, there are over 50 different ways to treat a bunion. A lot of why we do the things that we do are based on what we learned in training and the level of deformity or the severity of the bunion. And with the traditional open procedures, we tend to do an osteotomy or a bone cut, either distally, and hopefully you can see my arrow here, like more closer to the joint itself, or more proximally, closer to the heel. And then there's also what many patients come in asking me about is the Lapiplasty or the Lapidus, which is a fusion of the first tarsal metatarsal joint. And you can correct a bunion that way. And, it's the Lapiplasty is a particular procedure. It's done a really good job of marketing itself. But I think in my hands, there's a time and a place for the Lapiplasty, which is essentially a fusion. So meaning permanent loss of motion at this joint down here, the first tarsal metatarsal joint. And for me, I kind of do that in really severe disease, someone who's very, very flexible that might have an increased risk of a bunion recurring, or if there's arthritis there. So, and that's just showing you how good they are at marketing. So the traditional open procedures, it involves a pretty big incision along the top of the big toe or along the side of the big toe, and in order to access everything, that requires a lot of soft tissue stripping to expose the bone. And that can be really painful. And we'll get into that a little bit afterwards in terms of some of the consequences of that. So again, these are larger incisions, more soft tissue disruption, more swelling, and that leads to a higher risk of wound complications, infection, long-term swelling. I tell everyone that swelling is normal after foot and ankle surgery for about a year, but obviously with less soft tissue disruption, that swelling can really be minimized, and that's what I like so much about the MIS bunion correction. And then stiffness, right? With swelling comes stiffness. It's the longer you're stiff, the less range of motion you're going to have during that time, and the harder it is to get that range of motion back. So a little history about minimally invasive surgery. It was really trendy in the 80s, and that was in the United States. We, as surgeons, we started to do this MIS surgery, but what we found was that patients didn't really do well. The results weren't reproducible. There were a lot of soft tissue complications. And as we were trying to learn this technique, and this isn't just MIS bunions, but minimally invasive surgery in general in orthopedics, we were having a lot of high revision rates and recurrence. So it kind of developed this stigma, and it lost favor in the United States. Meanwhile, though, over the next 20 years, it actually gained a lot of popularity in Europe and other countries, and new technology was developed. And what surgeons were finding was that there were better outcomes through smaller incisions, which led to a faster recovery. And then with the boom of the internet during this time, word started to travel, and there was this greater education focus on education. And we have tons of courses now, all focused on performing MIS surgery. And in particular, in the foot and ankle world, we have courses specifically designed for MIS bunion correction, which is great. And then the last thing is with the opioid epidemic, we found that with these MIS surgeries, patients had less pain, which in turn allowed them to take less narcotic pain medication. So the minimally invasive bunion, how do we do it, right? So we use a few small incisions. And usually what I tell patients is, instead of one big incision, I'm going to do about 6 to 8 small incisions throughout the big toe in order to achieve the correction. And that 6 to 8 kind of depends on the severity and the deformity, any concomitant deformity that you may have. And what we use to correct this, and I'll show you a picture of it shortly, is this low speed, high torque burr. And we call it, it's called a Shannon burr. And it's low speed, so that means less heat, so less thermal necrosis, meaning less burning of the bone, and less soft tissue complications. And you can see there, the average speed for this burr is about 3,000 to 6,000 RPMs, where a traditional burr that we use in orthopedic surgery is up to 40,000 RPMs. So really, it's cutting through the torque, and that's what makes it lesser risk to the soft tissues as well. So you can actually put this burr on your glove, like your surgical glove, and it won't catch the glove. Whereas, most other power tools in orthopedics, if you did that, it would wrap your glove up pretty quickly. So even if the burr were to touch your tendon or the soft tissues, it won't just cut right through the soft tissues, which is great. And this is an example of all those different burrs that we use. The Shannon burr is the traditional thin burr here. You can see my arrow on it. And that's what we use to do the osteotomies or bone cuts. And then these thicker wedge burrs we can use maybe to shave down the bone and to breed any sharp edges that might be there. And again, yeah, it's great. It's very low risk to the soft tissue. So you can put it on your glove and it won't catch your glove. So in particular, the MIS bunion correction has a couple different names. So we call it like the MICA or the MICA and the MITO and the PICA. And basically, these are just abbreviations for minimally invasive chevron Aiken, which is basically 2 different types of bone cuts, or minimally invasive transverse osteotomy, again, another bone cut. And percutaneous, which is the PE, chevron Aiken, which is, again, the 2 different bone cuts that we make. So you might hear your surgeon using those slang terms, and basically what they're talking about is the MIS bunion correction. And again, like I touched on before, while this was first introduced in the 1980s and then expanded upon, we didn't have great outcomes in the beginning. And the reason for that in the beginning was because we'd make the bone cuts, but we didn't use any hardware. So no screws and not even any pins to hold the positioning of the toe in place. They just would tape it and use soft dressings. And so we found that it was hard to hold that correction. And so this expanded about 10 years later, and there were some foot and ankle surgeons that decided, why not use a pin to help hold that correction? And you can see here in the photo, the osteotomy or the bone cut here is at the metatarsal neck, and this is a transverse osteotomy, so a straight cut. And then we slide the head over, and then lock it in place here with this wire, which basically moves the head over and eliminates that bunion deformity. But there was a big study that came out in the early 2000s, and they found that it wasn't a reproducible technique. Patients were having poor results with lots of complications, such as the bone not healing, their bunion recurring, and they were having wound complications. So again, MIS bunions kind of lost favor. But then these 2 surgeons, Vernois and Redfern, they in the 2000s, they developed the modern technique. And that's what we're using now. And it consists of a distal metatarsal osteotomy, meaning a bone cut here at the metatarsal neck. And then it can either be done transverse, which is what I do. It's a straight cut across, and that allows me to change the rotation of the head as well. Because with a lot of bunions, we end up the toe, you might notice that your toe is also rotating. So we want to de-rotate that head. And with that straight cut, we're able to do that. Some surgeons also use a chevron cut, which is basically like an arrow or a V. And then we fix it with 2 screws. And in the beginning, these screws weren't beveled like they are now. So I use a beveled screw, which allows me to place, you can see here, place it directly up against the bone. So that way you don't feel the screw head at all. So that's been a really nice update to the MIS bunion correction. And then this is an outpatient procedure. I do put patients under general anesthesia just because we are using instruments and the toes are small. And if the patient were to jerk, we don't want to cut anything we don't want to cut. I use local anesthetic for postoperative pain relief, and usually that'll last, through the evening. And then most patients are off of their narcotic pain medications within 2 to 3 days, which is great. So this is just what it looks like in the operating room. So the burr is in my right hand there, and I'm using X-ray to see everything that I'm doing. So because I'm using these small incisions, I can't actually look at the bone. So everything is done under X-ray, and you can see the foot balancing on the X-ray there. And so I'm actually looking at X-ray while I do this to make sure I'm cutting in the correct places. And that's how I can judge how much to correct and where to place the screws as well. And then here's an example of the different tools that we have now in order to make this surgery even more accurate. So this is a little head pusher, and this is what I use. So we insert it through one of the incisions, and it actually has this little jig where you can twist it, and it helps push the head over and dial in the correction that you want, right? Before, this patient's metatarsal head was all the way out here. And that's what caused the bump that you feel, or the bunion. And after we cut it, we're able to move it over, and then we hold it in place with the K-wire. And then, you can, if you want, there's a special guide that actually triangulates the screws in the correct position as well. I don't use that. I freehand my screws just because that's how I was taught, but that's certainly a nice option. And then you can see after all that, this is kind of what you get at the end. And a lot of my patients will come in and they'll say, that X-ray looks crazy. And I agree, it does look kind of crazy. But I'll show you some photos how you'll see the bone actually heals over time, and you get this nice bone bridge. And you'll look and see that the skin is actually nice and straight, and that's the correction that you're looking for. So here's an example. This is immediately post-operative. You can see this if you draw a line along the skin, how straight that toe is now. And you can see, this was 1, 2, 3, 4, 5, 6, 7 different stab incisions in order to get that correction. And each incision just requires 1 suture to close, nothing deep. So it heals up really nicely. So here's some of the big benefits with the MIS bunion correction. Definitely a faster recovery. And I think a lot of that is due to the less swelling, and then the less pain that the patient is having. We also have to worry less about wound complications because these incisions are so small. So a lot of the time with foot and ankle surgery, we have this, 6 to 8 week rule where patients are non-weight bearing in order to allow the incision to heal. With this, the incision is pretty much healed at their first, your first post-op appointment in about 2 weeks. So that takes that out of the equation, and then it's all about bone healing. So I actually allow my patients to perform early weight bearing after this procedure. So you're allowed to heel weight bear the first 2 weeks, and then at 2 weeks, you're allowed to fully weight bear in this special shoe that I'll show you, which is really nice and helps, patients slowly get back to life a little bit quicker than with the traditional open procedure. It's usually about 6 weeks of non-weight bearing, and then you're protected in a boot or a shoe for a little while. So again, we see less wound complications, that reduced risk of infection, triplanar correction, meaning I get to rotate the metatarsal head or your big toe around just to make sure that you have a nice and straight toe. And then the bone cut that we make with this approach is outside of the joint, again, so there's less stiffness. And we're not cutting the capsule, which is the tissue that surrounds the joint. So that can scar up post-operative. So since we're not doing that, you get less scarring and again, less stiffness. So here's an example of a pre and post-operative patient. So you can see the large bunion deformity here, and then you can see the nice straight border over here. And you can see this little pouching here. That's actually all soft tissue, so that's not bone. And when you have a bunion, all this tissue out here on the inside stretches. And so you're still gonna have this little bit of extra skin. Over time, within like the first 3 months, that all goes away, which is nice. So you really will have this nice straight border. And then here's what x-rays look like. So you can see the transverse or straight bone cut here, where we slide the head over and then we lock it in place with 2 screws. And then that's called the transverse osteotomy. We actually say chevron a lot, even though it's not really a chevron cut. And then this is the Aiken osteotomy. So it's a bone cut of the proximal phalanx of the great toe. And I use that burr to actually take a little wedge of bone here out of the proximal phalanx, and then I push the toe over and then lock it in place with a screw. And that just gives us a little bit of extra correction. And then here's the lateral view. You can see the 2 screws are all the way in bone, both here in the metatarsal and the proximal phalanx. And you can see the screws are also buried here along the medial edge. So you won't be able to feel those screws whatsoever. They're 100% in bone, which is nice. And then here's an example of a patient who's 2 weeks post-operative. So you can see there's really minimal swelling. Here are the steri strips we put on. The patient had minimal pain. You know, we weren't worried too much about wound complications. The patient went on, you know, to shower that day. And then this is an example of a patient 6 weeks post-operative. So you can see those incisions are completely healed. And then if you take a look at the medial border of the foot, you can see how straight that is now, that the swelling's gone down, and that little pouching of tissue is actually all decompressed. Another example of a patient at 6 weeks post-operative. All right. This is a nice picture of a patient who is 2 weeks post-operative here, and you can see the patient has this soft tissue swelling, that extra skin that we talked about, and you can see that the x-rays look kind of crazy, that there's no bone bridge yet. The correction is really held together here based on the stability of that transverse cut and then the 2 screws. And then here patient is, they were around 4 months here, and you can see that the bone bridge has completely healed. They made all this really nice bone. And then if you take a look at the skin border, you can see it's nice and straight. So the post-operative protocol, you know, the one thing everyone cares about the most, when can I get back to all the activities I enjoy? So it's 2 weeks in a soft dressing, meaning some bandages that I put on at the end of surgery. And those stay on until you see me in the office, and I take them off in the office with the sutures. And during those first 2 weeks, when you're in that soft dressing, you can heel weight bear. So you can walk around on your heel. You'll just put no pressure through your forefoot. And then at your first post-op visit, which is around 2 weeks, those sutures will come out. You can go ahead and shower. The only thing we limit is like pools and baths and hot tubs or getting a pedicure. I try to limit that for the first month just to help prevent any infection or any dirty water from getting inside the foot. And then you are allowed to full weight bear in that post-operative shoe at the 2-week visit. Here's an example of what that post-operative shoe looks like. So there's 2 kinds. There's one with a heel wedge. Some patients like that because then they don't have to hold their foot up in that heel weight-bearing position. But you can also just use a standard flat post-operative shoe here. And that's what we give you in the office, and you bring it with you to your surgery and leave with that on. So at 6 weeks, I have patients go into a regular shoe. So I tell them, bring a shoe if you feel comfortable, or it's a gradual transition from that 6 week visit, over the next couple days to a few weeks, depending on your tolerance and your level of swelling. But at 6 weeks, technically you're allowed to go into a regular shoe. And then once you're in a regular shoe, that means if it was your right side, you can start driving. You can walk for exercise, you can swim, you can bike, you can do low impact activities. So really at that 2 to 3 month mark, you are comfortable walking, swimming, biking, and doing low impact exercise. At 6 months, as long as we're assuming no complications and the bone is healing, there are no restrictions. You can get back to sports, running, jumping, anything you'd like really. And then, I always say it's a year recovery. So you'll probably be back to normal around that 6 month mark, but it still takes a year before you kind of forget that you had surgery, before maybe all of the swelling goes away, and before you stop, thinking about the little aches and pains here and there, or maybe some random numbness or tingling. And this is one of my patients here at 2 weeks walking in her postoperative shoe after I gave her permission. And she was able to walk down the hallway, which was great. And then the literature, there's lots of studies now that are in support of the minimally invasive bunion correction. And most of the studies have found that it is equal to an open procedure. So it's just as safe as an open procedure, except we're finding that there are small advantages, right? Like the wound complications, the reduced risk of infection, the quicker return to recovery. And a lot of that is anecdotal from the surgeons who are doing this procedure, but it's real and patients are really happy about it. And I have a lot of patients who get their first one done if they have, bilateral hallux valgus deformity. And then within 6 weeks, they want their second side done because of how much they enjoyed their experience, which is really nice. And this is just a big study that has basically reviewed all of the studies that have been done recently and found that it is safe and effective with a low risk profile, but there is a significant learning curve. So I had the benefit of learning how to do this in training. So I've had some experience with it, but I think that it is definitely something that is still growing. And it's important that if you were to have this done, you want it done by someone who really has the experience and training to do it effectively. So in summary, the MIS bunion is a safe and effective surgery. We find that patients have less pain, less swelling, and less wound complications. And lots of my patients come back for their opposite side within 6 weeks, which is kind of telling. So thank you very much. And hopefully you guys enjoyed that and learned something. All right.
We have a couple questions, Dr. Moncman.
Perfect. Right. Let's see. Okay. As a long distance runner with a bunion and some loss of padding in the ball of the foot, what option do you recommend and how long until you can get a shoe on and run again? So if the pain is along the bunion, then you can correct the bunion. And then if there's pain along the bottom of the toe, it depends. If the pain is along the bottom of the big toe, that's a little bit more difficult because that's sesamoiditis or pain along the sesamoid bones. If the pain is along the ball of the foot, like more so on your small toes, that's called metatarsalgia. And what we can do with that is either for conservative treatment, you can always try a metatarsal pad. And if that doesn't work, we can do a surgery called a while osteotomy, or basically a shortening osteotomy of the second metatarsal. And basically what that osteotomy does is it shortens your metatarsal and then offloads the joint a little bit. And that takes pressure off of it. So when you're walking, and it helps that pain on the bottom of the foot pad. Realistically, I tell patients that if you have that procedure done, you're probably not going to feel strong enough and comfortable enough to run until about 5, 6, 7 months. But I do have patients that have gotten back around like 4.5 months, but I would say that's less common, and you're more looking at an average of about 6 months before you're back to running. All right. I will need to get a hip replacement and also bunion surgery on the same side within the next year. Which would you recommend doing first, or both at the same time? Okay, so I don't recommend both at the same time. I have a lot of patients that ask about getting both bunions corrected at the same time, and I just feel like that's too much surgery. I don't think you'd maximize or optimize your recovery as much. In order to have a hip replacement, you have to have a stable contralateral side, I would say. Same thing with the bunion surgery. If it were me, I would say fix whatever hurts more. So if the hip is bothering you more, fix the hip. If the bunion's bothering you more, fix the bunion. I think that would be my suggestion, but I don't think there's any right way to do it. I would just fix which hurts more. Will osteoporosis be a deterrent as to whether to go forward with this surgery? Not typically. So if you have poor bone quality, we don't necessarily not do the surgery for that reason. I don't tend to do a bunion correction in patients over 65 years old. Usually, if you have a bunion at that age, you probably have some arthritis in your big toe. So we tend to go more towards a fusion at that point. Not to say I haven't done it in a patient older than 65, but we do worry that if we correct the bunion, the patient could still have some arthritis in their big toe, and then we'd be setting you up for failure. So I am a little bit more pro first MTP joint fusion when there is osteoporosis or some arthritis at the big toe. It just kind of depends on your symptoms. But it's definitely not a deterrent necessarily. It's definitely a conversation. All right, next question. How about soft tissue release to mobilize the sesamoid bone? So you can do a little MIS distal soft tissue release. I've done that a few times in bones that are in deformity that is particularly rigid. And basically what that is a release here along the first web space, and you're releasing a ligament there, and you're releasing the sesamoid and perforating the capsule to loosen up the tight structures here on the lateral side. It's certainly something I do on occasion. You just have to be careful because you don't want to strip the blood supply accidentally and cause AVN of the metatarsal. Do you have x-rays of 6 and 12 months post-op? So I don't have pictures of the, here, I'll go back, x-rays. Let me see if I can go back. Let me find that 4 months x-ray. Can you guys still see my screen or no?
Not right now.
How about now? No?
No.
Okay, now can you see it?
Yes.
Okay, perfect. So this here is considered healed. So this picture here on the right, that was about 4 months post-op, it doesn't look different at 6 months and 1 year. So if this little indentation is just not something we worry about, because the bone and the malalignment, it doesn't affect the patient in any way. It's stable, it's strong. And what we look at is the medial border of the foot. So you can see that the medial border of the foot is nice and straight. So that is the correction, and that is what it typically looks like at a year. So it's not like, so we don't fill in any more bone over here or over here. You wouldn't want to. You do have this angled repair site. Right, go back to this, go back to our questions. How long is the foot exposed to the x-ray during the procedure? Yeah, so definitely more X-ray than in open approaches. There are studies. We actually just did a study looking at that, and it did show that it was almost double the amount of time. It depends on, I think, the surgeon, but maybe on average, you're taking about 90 seconds worth of X-ray, right? Because it's not like it's continuous X-ray. It's just individual shots. So my guess would be maybe about 90 seconds. You know, I wear lead. We have our all of our assistants and our scrub techs wear lead as well. But that is definitely something that's increased with the MIS procedure. Are there options for, I think this is removing corns? So the calluses that you form from the bunion will go away on their own, if that's what this question is talking about, over time, because you no longer have that deformity. And then I personally don't remove corns. I'm an orthopedic surgeon. But I know that there are a lot of local podiatrists that remove corns and probably have some good suggestions for that. Which Rothman surgeons in the Philadelphia area perform this type of surgery? So Dr. David Pedowitz, and he's the one that trained me. He's the one that does this surgery. Any contraindications for this procedure? Yeah, so in general, uncontrolled diabetes is always a contraindication to surgery. So hemoglobin A1C should always be less than 7. Otherwise, you risk wound complications, infection, and non-unions, or the bone not healing. Other contraindications for me, if you have arthritis at the big toe, then we don't want to do this procedure, because ultimately we're setting you up to probably need another surgery in the future, and your pain not be completely relieved, because some of that pain may be coming from the arthritis. So that is a contraindication if there's arthritis at the big toe. If you have arthritis or hypermobility, meaning increased motion at your tarsal metatarsal joints, or painful arthritis at the tarsal metatarsal joints, then we need to talk about other procedures, such as a fusion procedure, just because there's a higher risk of recurrence. And then also, we don't want you to have another procedure in the future again for arthritis. But for the most part, we're doing MIS bunion corrections in anywhere from mild to severe deformity, and patients are doing really well. All right. Next question. My big toe impinges on the second toe, pushing it inwards. Yeah. So not sure whether the second toe is actually elevated and crossing over the big toe or not. Most of the time with a bunion deformity, it is crowding the second toe and pushing into it. So when that happens, we absolutely correct it at the same time. Sometimes you don't need to correct it, because once you correct the big toe, then the second toe is okay. It's not getting impinged on anymore. But if it's been chronic and going on for a long time, that second toe deformity might be more rigid, meaning we have to fix the second toe as well. And usually that's a combination of different bone cuts. Typically we do shorten the second metatarsal, it's called the Weil osteotomy that I talked about before. And we put a little screw to hold it in place. And then sometimes you get that like hammer toe or clawing deformity as well along the lesser interphalangeal joints, and we correct that also. I do it minimally invasive. So I use my little burr, and then I either use a K-wire or a screw, depending on the patient's preference, to lock those corrections in place. All right, with the MIS techniques, is it reasonable to consider a return to activities that require weight-bearing great toe extension, like push-ups, martial arts, and what guidelines would you recommend for these patients? So, yep, with an MIS bunion correction, you can absolutely go back to all of those activities. Again, it's kind of more along that 4, 5, 6, 7 month mark that you'll be able to go back to those activities. But I have you work on range of motion exercises, after your 2-week visit, because we don't want that big toe to get stiff. So I would absolutely we want you to go back to those activities. That's the point. So there'd be no restrictions in regards to that. Can you use the MIS approach if there is a cyst within the bone? So most likely, I don't know if the cyst is, if you're talking about the cyst being in the metatarsal bone itself or a cyst within the metatarsal head. I'd be a little wary that if there is a big cyst within the metatarsal head, then there might be some, a little bit of arthritis going on, or maybe my screws wouldn't capture enough bone and you might lose correction. So it would depend on the size of the cyst and where it's located, but certainly it wouldn't be an automatic contraindication to doing the MIS bunion. All right. A patient's going to be walking a lot in Europe, and we'll be getting some good shoes and breaking them in beforehand. They're going to look into a metatarsal pad for the plantar surface of the big toe. Yep, that's called a dancer's pad. Are there any other anything else to add for extra protection from trauma? Not too much. So the typical conservative treatments that I recommend for the bunion is you can use like a corn pad along that medial prominence. You can use a toe spacer. The metatarsal pad underneath is nice if you are having that plantar pain. You know, some patients, if not so much with the bunion, but if you are having pain with range of motion, you can always use like a carbon fiber insert. But most of the time I recommend a good stiff shoe, almost like a Hoka sneaker. It's got a natural rocker bottom. It's well cushioned. So for a lot of walking, something like that would be great. But unfortunately, there's not a lot you can do with the bunion since it is more rigid. You can't really correct it. Any kind of physical therapy after surgery. So you don't need to do physical therapy. Patients I recommend physical therapy for are those who are experiencing a little more stiffness. So they learn some good range of motion exercises for the toe, and anyone who's having trouble getting back to weight bearing, you know, after being on their heel for an amount of time, or if they've developed some atrophy. So it's just some, you know, light physical therapy for a month or two, just to kind of get back on their feet and help them get back to the activities they enjoy quicker. If my surgery is done before 65 and arthritis sets in later, what is the solution? That's a good question. So the nice thing is that because you don't disrupt the joint at all, you can still treat the arthritis. You probably would have to take out the screws, and to make room for, or you would have to take out the screws to make room for fixation for, let's say, a first MTP joint fusion, which is typically how we treat arthritis of the big toe when it gets to that point. And then we treat that fusion, the way we fixate it is either with screws or a plate and screw construct. So we'd probably just take out the previous screws and then lock the big toe in place with a plate and screw construct or just screws. So it does not set you up for failure in the future. And that's assuming you'd need surgery. You could always do injections and try a carbon fiber insert and some conservative options before surgery. And how long does the result last? Does it need to be redone after a few years? We're finding that the rates of recurrence are low and similar to the open procedures, and that there is no expectation that it needs to be done after a few years. You know, there's always a risk of recurrence with bunion surgery, and that's with the open or the MIS procedure. But this is not something that is it's not designed to be a temporary fix that you have to redo in a few years. Yeah, it's designed to last. Good questions.
All right. Well, thank you all for taking time out of your schedule to join us this afternoon. And thank you to Dr. Moncman for sharing such valuable information. I hope you all found this information helpful. And if you have any questions, please email me, which you will find in the chat box, and we will get back to you as soon as possible. Again, if you would like to make an appointment, please call 1-844-407-4070 or go to rothmanortho.com. Thank you.
Thanks, everybody.